We go on to the next most important talk for which all of you are awaited. It is by Dr. Martin B. Leon.
Well, welcome, Marty. I know it's in the middle of the night there, and thank everybody over there who's behind you as well, the team of folks who opened up the studio. But I think you have a packed house here, and everybody's eagerly awaiting your talk. So Marty needs no introduction, and here he is. Can you hear us?
Very much. Of course, I'm disappointed that I couldn't be there in person. I'm expecting to have my visa in my hands by tomorrow morning, which obviously does us no good. So I want to really thank my colleagues here in New York, because they've gone to great lengths to try to help with this transmission. So people like Jeff Shamley and Michael Hauk and Johnny White have all been instrumental in making this happen in the middle of the night. I also want to acknowledge and thank, of course, Sushil Kodali, Ajay Kurtne, Gary Mintz, and Srinivas Kumar, who've done a spectacular job in putting on this program. So let me begin now and do my best to summarize what has been a very interesting career in interventional cardiology. The echo is horrible. Next slide. I began my career in interventional cardiology in 1978. I was in my 20s. I was working at the National Institutes of Health as a clinical associate, and I assisted Kenneth Kent in doing early balloon angioplasty procedures. And I have a perspective over the last 35 years in many of the interesting changes that have occurred in our subspecialty. So I'm going to, in condensed fashion, do my best to see if I can summarize some of the important developments and stages of interventional cardiology, and also try to focus a little bit on the future. Because although I may be more towards the terminal portions of my career, most of you are younger than I am and have very productive and fulfilling careers ahead of you. So I'd like to project and at least have you appreciate what you can expect to see over the next 5 to 10 years as well. As you can see here, there are many early pioneers in interventional cardiology. I never had the opportunity to meet Werner Forsman, but I have met Mason Soames, Charles Dotter, and of course Andreas Grunzig. And Andreas Grunzig, the father of balloon angioplasty, his tool was a fixed wire balloon, which was fabricated on his kitchen table and allowed us to do the first interventional catheter-based procedure in patients that were alert, awake, and in catheterization laboratories. Next slide. Of course, his dream was that catheter-based percutaneous treatment be accomplished in patients with vascular disease who were alert. Next slide. So let me quickly just review the early days of balloon PTCA and early stents. Next slide. If we had to summarize the saga of balloon angioplasty, which is the first decade of interventional cardiology, I think we can say that there were frequent dissections, recoil, poor angiographic outcomes, acute closure requiring surgical backup, and relatively ineffective outcomes in certain lesion subsets, particularly calcified lesions. And of course, the beginning of restenosis. And truth be known, restenosis occurred with balloon angioplasty in as many as 40% of patients, particularly patients with high-risk lesions and diabetics. In one of the early journals in the 1990s, you'll see that somewhere between How to Lose Your Belly and the Great Condom Test, next is an article that says a balloon goes bust. So clearly, balloon angioplasty by itself would not have been enough to sustain the subspecialty of interventional cardiology. Next slide. The next phase was a curious era where we looked at a variety of new devices: laser angioplasty, various forms of atherectomy, and the early days of stents. Next. This is a very early laser hot-tip catheter, and this was an article in a medical journal. And as you can see, it says you've never used a catheter like this before. Next. And I can tell you, having used this catheter, that once you did, you would never want to use it again. Coronary atherectomy. Extraction atherectomy is shown here. Directional atherectomy that you're all familiar with. And of course, rotational atherectomy unfortunately did not achieve what we had originally expected. We can summarize this new device angioplasty era as follows. We saw frequent complications, including increased perforations. We saw some improvement in complex lesion subsets, especially calcified lesions, but it required much greater operator expertise, it was more costly, and the restenosis rates were even higher. Next. So clearly, the new device angioplasty was still not good enough. But I will say in the early days, the original Palmai-Schatz stent. As you know, this was a tubular slotted stent, 15 milligrams of stainless steel with a central articulating bridge. This version was balloon expandable, and this was the first important development in interventional cardiology beyond the balloon. Next, pioneers like Ulrich Sigvart, Julio Palmaz, and Richard Schatz are all shown here. And this was the first case that was performed in a human in the end of 1987 by Eduardo Sousa in Sao Paulo, Brazil. Next. It took 6 years of agonizing studies in the United States to finally see the balloon expandable stent approved by the FDA for commercial use. Next. And finally, we were off and running. I would describe everything up until this point as being the age of empiricism in interventional cardiology. So the early days of balloon PTCA, through this new device era, the determination of clinical value was assessed by case experiences, by word of mouth, and in non-rigorous observational studies. This was more of a pseudo-surgical approach, and it resulted in overly simplistic and often incorrect impressions of many interventional device therapies. And we should really learn from this experience. So as we try to use a variety of new devices, that we should insist that more rigorous clinical evidence-based medicine be the standard for clinical application. The FDA-approved Palmai-Schatz coronary stent, which was 1994, was the first device approved on the basis of randomized controlled trials, Benestent and stress, and this ushered a new era of evidence-based medicine in interventional cardiology. The next important development was the drug-eluting stent era. So as you're all aware, bare metal stents had some wonderful features, made angioplasty safer, more predictable, and certainly a lower restenosis rate, but we still in many patients saw diffuse in-stent restenosis as shown here. So it became necessary to combine a device with a drug, and the first advanced biotechnology platform in all of medicine was the drug-eluting stent. This is a 3-component system, including a stent, of course, a pharmacologic agent, which has an effect on aplasia, and a drug carrier vehicle that would elute the drug with very specific pharmacokinetic properties and allow enough drug to be in tissue to exert an effect over at least 30 days to significantly affect early intimal hyperplasia and late restenosis. This is a wonderful concept that was initially studied in animals with moderately, but then was brought into early human clinical trials. Next, the two first-generation drug-eluting stents were the Cypher and the Taxus stents, different drugs, different polymers, and different stent designs. I must say that the polymers, which are durable polymers, were not designed for this application, and we learned later that the properties of the polymers probably contributed to some of the pathobiologic changes that we saw with early drug-eluting stents. Next. But striking to us was the impact on restenosis. This is the first case that was ever done also in Sao Paulo, Brazil, in December of 1999, again by Eduardo Sosa. And you can see in this diabetic, in the LAD, the initial result treated with an excellent immediate outcome, but the sustained results, which are out to four years here, and this patient has had a 10-year angiogram, and the result is exactly the same. After the initial series of patients, Patrick Sorais declared that restenosis was cured. This was his rosy prophecy, that drug-eluting stents would finally cure restenosis. We were all very excited with these early days of drug-eluting stents in the early 2000s. And you can see in Sao Paulo, after the follow-up was completed, there was abject euphoria with zero restenosis. So these early days of drug-eluting stents, up through perhaps 2006, resulted in a dramatic penetration of drug-eluting stents in the United States to about 90% of cases. People felt that restenosis was solved. The pivotal data in clinical trials looked very good from the standpoint of safety and efficacy. And many people felt they were good for all lesion types and in all patients. However, we also learned that drug-eluting stents certainly had favorable characteristics, including very low late loss and low restenosis, but also some unfortunate characteristics. There was markedly delayed healing. There were inflammatory changes and hypersensitivity reactions. There was abnormal vasomotion. We saw incomplete apposition, late new incomplete apposition, which was a new finding, and then late stent thrombosis. And it took us almost 5 full years to appreciate that in a small percentage, but a significant percentage of patients, we observed this new phenomenon of very late stent thrombosis. In August 2006, at the European Society of Cardiology, after reviewing many of the data with drug-eluting stents, it was felt that these devices may in fact increase mortality. So there was a dramatic response to this, and this really was the beginning of the dark days of drug-eluting stents, where there was a significant drop in the penetration of these devices because people felt there was an increased frequency of thrombosis and perhaps mortality. At the same time, the COURAGE trial was driving more aggressive medical therapy, and many people, both interventionalists and non-invasive cardiologists, felt that these devices should be used much less frequently and only in particular clinical scenarios. During that time, there was an explosion of evidence-based medicine. Over 2,500 peer-reviewed manuscripts on drug-eluting stents were published over a decade between 2002 and 2012 in an effort to better understand not just the early but the late outcomes. At the same time, technology was moving forward, and second-generation drug-eluting stents were being studied, and many of these are, of course, in clinical practice today. like the Xience V or the Xience Expedition, and the Resolute stent shown on this slide. Now the stents themselves were more modern stents, more flexible and more deliverable and made from cobalt alloys. The drug doses were diminished somewhat, and importantly, the durable polymers were designed with specific characteristics that were far more biocompatible and safer for the patients. So now we're at a point where the penetration of drug-eluting stents, at least in the United States, has gone back up to almost 80%, where most people believe that PCI with drug-eluting stents is certainly advantageous for symptom relief and reducing ischemia. The overwhelming data does not indicate an increase in mortality or MI, and target vessel revascularization rates in the real world are reduced by about 50% compared to bare metal stents. So there's much more confident DES use, but with careful dual antiplatelet therapy. And of course, this is being discussed during the course of this meeting. There are still many changes and refinements in the use of drug-eluting stents. But the era of drug-eluting stents, I think, helped us to evolve from that age of empiricism to now a period of evidence-based medicine. And this transition really has distinguished interventional cardiology as a modern subspecialty, which is committed to scientific principles and the highest ethical standards of conduct. And certainly now and in the future, all new important therapies will require evidence-based medicine validation in the form of well-conducted clinical trials. I think all of us appreciate that evidence-based medicine is not perfect, and if the data are not interpreted in a balanced fashion, it can result in more confusion than clarification. And of course, there are other factors beyond clinical trials that must be heavily weighed to optimize clinical decision-making. We're now in an era where vascular drug delivery is moving even further ahead with 4 third-generation solutions. We're seeing metallic stents with a small amount of bioabsorbable, not durable polymer. We're seeing metallic stents with no polymer, fully bioresorbable scaffolds, as you've just seen in the clinical case, and also drug-coated balloons. Just some examples. The first of the metal scaffold but absorbable polymer drug-eluting stents was the Biomatrix, the Biomatrix 9 eluting stent. A large clinical trial called the LEADERS study was an all-comers trial with interesting outcomes suggesting a reduction in stent thrombosis compared to a conventional sirolimus-eluting stent after 1 year, suggesting that very late stent thrombosis may be reduced, perhaps on the basis of this absorbable polymer delivery system. A more modern version of the abluminal bioabsorbable polymer drug-eluting stent is the BSC Synergy, which has gone through extensive clinical trials, finishing a pivotal study in the United States as we speak, available for use in various portions of the world. So there are many new versions of bioabsorbable polymer metal scaffold drug-eluting stents that we'll be seeing in clinical practice. If we go one step further and eliminate the polymer, of course, there are polymer-free designs. This is the example of the BioFreedom stent. And this is an interesting design, not yet used in patients, but on the verge of initiating human clinical trials, which is a drug-filled stent where drug elution is controlled by diffusion physics from inside a hollow tube. You've already heard about fully bioresorbable scaffolds. There are many of them, certainly large randomized trials and registries being performed, and I'm sure over the next 5 years we'll have a good understanding of how these fully bioresorbable scaffolds will impact vascular drug delivery and coronary intervention. We're seeing some interesting findings that we did not see, of course, with metal stents, including positive remodeling and restoration of normal vasoreactivity with these bioresorbable drug-eluting scaffolds. Next slide. So I would say that currently DES are certainly good, but they can get even better. And future technology that I've described certainly, I believe, will have a positive impact, perhaps on efficacy, but certainly on safety. One slide simply to introduce drug-coated balloons, which I think will have application in certain areas, both in the coronary and peripheral circulation, available in certain parts of the world, being used for in-stent restenosis and small vessel disease, and in peripheral applications, but again, another form of modern vascular drug delivery. During the course of at least my 3.5 decades in interventional cardiology, one of the interesting observations has been the evolution of the cath lab. And the cath lab, which was a relatively static environment, has become an extraordinarily dynamic and multidisciplinary venue. Many of the things that we're seeing in the cath lab include increased safety and comfort for both patients and the operating team, working much harder to improve and get consistent clinical outcomes, increased efficiency of how we operate in the cath lab, multifunctional capabilities allowing us to do different procedures with multimodality imaging and also surgeon-friendly, allowing multidisciplinary teams, which represent vastly different subspecialties, to work together. It's a fully integrated environment with hardware, software, new digital monitors, which is IT enabled for data management and for also pre and follow-up diagnostics. So many changes right now in the cath lab. One of the reasons why we see those changes is that the cardiology market is shifting dramatically. Whereas it was based on vascular intervention up through 2010, I can predict with certainty that in the next decade through 2020 that we'll see a doubling in the worldwide number of procedures and in the worldwide economics of interventional therapies, but it will not be on the basis of an increase in vascular intervention, but many new segments, such as valvular heart disease, hypertension, structural heart disease, things like left atrial appendage closure and adult congenital closures, and other things that we can't even imagine yet. Let me spend a moment on some of the enhanced diagnostics that are being used in a cath lab and modern cath labs, and you see it in some of the live cases that are being transmitted to this important meeting. Much of it is driven by an aggressive attempt to try to establish criteria for how we do vascular intervention. So you're all aware of the appropriate use criteria to define when we should or should not be treating patients with coronary disease based upon, to a certain extent, a single clinical trial which has subsequently been validated, which indicates that invasive assessment of ischemia is an important consideration to optimize clinical outcomes, certainly to improve safety, to reduce complications, and to reduce cost. And of course, this was the FAME trial. So FFR, fractional flow reserve, is being used widely now in most parts of the world, and as a diagnostic procedure has an annual growth rate of between 10 and 20% predicted over the next 5 years. There are other attempts to apply these kinds of ischemia assessment techniques. This is an example of the HeartFlow non-invasive CT FFR system, which has been studied now in a clinical trial called the de facto study. Several other studies, they're in process. Some will be reported at TCT. So clearly, other non-invasive techniques are trying also to understand exactly which vessels are causing ischemia to justify intervention. So the cath lab is no longer just a therapeutic environment, but online invasive diagnostics are an important consideration. We're seeing advanced imaging systems. So new tube detectors like this, these new detector technologies and tubes will significantly reduce the dose of fluoroscopy and improve resolution. We're seeing new hybrid cath labs which have multidisciplinary flexibility and then improve the efficiency, safety, and some of the procedural efficacy for complex treatment scenarios. This is an example of one of our hybrid cath labs at Columbia where surgeons and interventionalists work together. This is a routine environment for both valvular and structural procedures and many endovascular procedures in many labs around the world, and I believe will be a standard for many of the new procedures being done. Multimodality imaging has become commonplace. We started with simple grayscale IVUS. There was virtual histology, high-resolution IVUS being developed, OCT, forward-looking IVUS being developed. So many techniques which are intravascular imaging techniques that will give us greater ability to diagnose specific situations and to monitor therapy. In structural heart disease, we expect both planning and guidance is going to be accomplished by integrating and co-registering a variety of imaging techniques with standard fluoroscopy. So unlike previously, where fluoroscopy and city angiography were the two major modalities, we are seeing echocardiography, imported CT angiography, MR studies, and multiple overlays to be able to help us to both diagnose and treat patients with complex valvular and structural heart disease. We're beginning to see the early stages of robotics entering the interventional cath labs. So as is commonplace around the world, haptics and robotics have become an important consideration in minimally invasive surgery, and certainly the younger generation has much better hand-eye coordination. We believe, and there's good evidence to suggest, that robotic-assisted procedures improve teaching. There's more consistent procedural technique, reduced hospital stays, and also other clinical outcomes are similarly improved. We're seeing a dramatic growth with an estimate that there'll be over 1 million robotic procedures done by 2015 around the world. In one of our cath labs, we have the Corindus CorePath system, which is an operator console which moves guide wires, balloons, and stents remote from the patient, which provides some interesting opportunities for both coronary and certainly in the future peripheral endovascular procedures. The first-in-man work was done by Juan Granada and his team. And then the pivotal U.S. trial was led by Gira Weitz from our group, demonstrating a high degree of successful procedures, but also a marked reduction in radiation exposure to the operator by over 95%. These days, everybody is talking about structural heart disease, and after drug-eluting stents, I would argue that this has been the next great transition in interventional cardiology. This is a difficult term to define. It's somewhat of a wastebasket term that refers to any catheter-based interventional procedure that's not associated with vascular pathology. This includes valvular heart disease, and here we're simply showing the current generation of transcatheter heart valves, the Edwards Life Sciences Sapien valve and the Medtronic Core valve. There have been over 75,000 patients treated through the end of 2013 in over 750 interventional centers around the world. Much of this work has now been validated with high-quality evidence-based medicine manuscripts, 4 manuscripts in the New England Journal of Medicine over an 18-month period describing the use of transcatheter heart valves in various patient subsets with either inoperable or high-risk scenarios compared to either standard therapy or conventional open surgery. Right now in Europe, the penetration of transcatheter aortic valve replacement is between 20 and 25% and has increased dramatically. In the United States, we see a similar increase and projected increase since commercial approval in 2011 and then 2012 with expanded indications. At Columbia, if we simply look at the case volume, in 2012 there were 308 implants done in patients at Columbia despite FDA regulation and control and limited access. There are many new systems that are available. This is simply showing you many of the new transfemoral systems that are being studied either experimentally or in early clinical trials, some of which have CE approval. Also many new transapical systems that are available as well that have CE approval and are being introduced to the European theater. Edwards, which developed the original balloon expandable device, now has a third generation device, the Sapien 3, and also a self-expanding device which is being studied. So there is dramatic development and innovation in the field of transcatheter heart valves. When you have a field that's been as successful as TAVR has been, there are many other accessory devices that are being developed to try to improve outcomes, including many large vessel closure devices shown here, and many transcutaneous ventricular access and closure devices that will allow you to be able to do a transapical procedure with a very limited thoracotomy and perhaps even simply transcutaneously. There are new deflectors and filters that are being applied and studied to see if we can reduce strokes by capturing cerebral emboli from the valve or from the ventricle during the course of this procedure. And we'll know certainly in the next few years if these devices will have an important impact on neurologic events. As we turn to the mitral valve, even though we started earlier in clinical trials with the mitral clip, the edge-to-edge repair from mitral regurgitation with the Everest 2 study, with results shown here where both the safety and effectiveness endpoints were met, this has been a slower process, more difficult to demonstrate efficacy to the point of widespread use with more limited applications currently. The landscape for percutaneous mitral valve repair is very, very broad, many new devices in many categories, including direct annuloplasty, previously coronary sinus annuloplasty. We mentioned edge-to-edge repair, chordal shortening procedures, and most recently, many different versions of mitral valve replacement devices that are being applied experimentally and entering the earliest phases of clinical trials. Extending further in structural heart disease, left atrial appendage closure for stroke prophylaxis in patients with atrial fibrillation we expect is going to become a large important area in the future. Here you see the Watchman device as it's placed in the left atrial appendage. And the most recent data from the Heart Rhythm Society conclusively shows a reduction in late mortality associated with placement of the Watchman device in multiple randomized clinical trials. Moving to the next important stage in interventional cardiology is the management of hypertension. It's interesting, in the past we had focused on vascular intervention. Now we're looking at mainstream major cardiovascular problems and applying remote catheter-based therapies to treat them in interesting and creative ways. So hypertension, as you know, is ubiquitous, with over 1 billion patients afflicted and perhaps as many as 35% uncontrolled with standard pharmacotherapy approaches. So there are new techniques using renal nerve adenervation procedures that allow us to be able to affect the sympathetic nervous system, both afferent and efferent, which has an important impact on hypertension. The first catheters are catheters using radio frequency to transmit current and energy to affect the sympathetic nerves that are in the periadventitial zones around the proximal portions of the renal arteries. The first important study, randomized trial, was the Simplicity 2 study, which is a relatively small randomized trial published in The Lancet in 24 centers. The primary endpoint was a reduction in 6-month office blood pressure, and the effects were absolutely dramatic, more so than could have been anticipated, and we now have a 3- and 4-year follow-up data in the earliest patients suggesting that there's persistence of the effect over time. We've completed enrollment in the Simplicity 3 clinical trial, which is a 530-patient randomized, unbalanced randomized trial in the United States, and we'll have the final results of this study presented at the ACC in 2014, and this was a treatment versus a sham control, a very interesting randomized trial that I think will help us to understand how this therapy can apply in patients with resistant hypertension. There are many new catheter systems. This is the new multi-electrode RF system that Medtronic is now using clinically in early clinical studies. These are 3 other RF systems from St. Jude's, Boston Scientific, and Covidien, using either balloons or multi-electrode catheters. Other ways to affect the sympathetic nerves using high-frequency ultrasound shown here, external ultrasound and catheter-based ultrasound still in early clinical trials, and ways of injecting specific drugs in the perivascular space that might also affect the sympathetic nerves around the renal arteries shown here. We're just beginning the era of catheter-based heart failure therapies, but we expect that this is going to be one of the most important areas over the next decade. The multiple targets include myocardial disease with sensors to monitor therapy, LV remodeling techniques, contractility modulation, microvads, and of course you've heard of stem cell therapies. The first sensor that's been available is the CardioMEM sensor, which has already completed an important randomized trial suggesting that it improves outcomes and reduces hospitalization in patients on heart failure. So by monitoring pulmonary artery pressures, you can titrate therapy earlier and more effectively than simply by other clinical means. This is an interesting parachute device from a company called Cardiokinetics, which is a technique for percutaneous ventricular restoration in patients with either akinetic or dyskinetic segments of left ventricle after myocardial infarctions, which is now being studied and has interesting promise. This next device is a partial support microvad, which is on a catheter. It's a very interesting system. So this is a system that is designed not to treat the end-stage patient with heart failure, but late class 3 and early class 4 heart failure with a very small device, which is implanted in the subclavian artery. It's an online pump, very small, as you can see here. The original characterization is done surgically, but now there is a catheter-based system which is done with a transeptal catheterization that allows you to capture blood from the left atrium and then to allow that blood to become injected into the subclavian artery through this pump device. Another interesting system is the DC devices concept to create an interatrial shunt in patients that have increased left atrial and end diastolic pressures, particularly patients that have pulmonary congestion in the setting of diastolic dysfunction. 10 patients have been treated using this device with initial promising results. This is more what it looks like. You can see it implanted in the initial animal studies, and we'll see much more of this over the next several years. So I've tried to point out some of the large areas in the future in terms of new catheter-based interventional approaches. So let me conclude by just talking about some more out-of-the-box concepts, things that are in the are more in the virtual stage, but it's very difficult to predict, but I'm certain that one or more of these may have important clinical application in the future. So there are 4 areas that I want to point out. One is multiple sclerosis. The other is erectile dysfunction. The third is pulmonary hypertension. And the fourth is obesity. So there's interesting data suggesting that CCSVI, which is chronic cerebrospinal venous insufficiency, may be one of the fundamental causes of multiple sclerosis. Zamboni and his colleagues from Italy have done extensive work indicating that we see multiple significant venous stenoses, either in the jugular or azygous veins, in patients with multiple sclerosis. And if you treat these patients with jugular vein angioplasty, balloons, or even stents, that many of them have a significant improvement. Now, much more work needs to be done, but this is an interesting early technique to treat patients with multiple sclerosis using catheter-based venous angioplasty procedures in either the azygous or jugular veins. Is it real? We'll need more studies to be certain. Of course, you're aware that erectile dysfunction is ubiquitous in men around the world. 80% of the time, the etiology is vasculogenic for a variety of reasons. And it usually involves an artery called the pudendal artery, which is a branch of the internal iliac artery. And that artery is about the same size as an LAD. It's often associated with stenosis that may contribute to erectile dysfunction. And this is an example of implanting a stent, a coronary stent, in the pudendal artery, as shown here. and an initial clinical trial in 15 centers called the ZEN study, enrolling 30 patients, showed an almost 70% improvement in objective metrics of erectile function at 3 months after angioplasty of the pudendal artery. So there may be interventional approaches to erectile dysfunction. There are new devices being developed for pulmonary hypertension. This is the first, called the ARIA implant, which is an interesting device which has a reservoir looking like a pacemaker, implanting a device with a balloon and a stent-like apparatus in the pulmonary artery. The balloon responds to pressure in the pulmonary artery. It's a completely passive device which acts like a fluid capacitor. It works extraordinarily well in animals and is about to engage in early clinical trials. There are other techniques which are interesting, looking at pulmonary artery denervation, sympathetic denervation with RF current, which have also resulted in significant reduction in pulmonary hypertension. And these are early studies that were just published in JACC and that will be presented at TCT in a few months. This is an abstract that was published several years ago in the radiology literature of a technique called GACE, which is gastric artery chemoembolization, which was done in pigs. What they were able to demonstrate was that ghrelin levels, which is a satiety hormone, which is liberated largely from the antrum of the stomach, are significantly affected if you embolize or if you alter the left gastric artery. So a study has already been done in 10 patients. This is the first 5 patients with exogenous obesity who had left gastric artery using microspheres of a certain size with dramatic weight loss, with no periprocedural complications, with no evidence by endoscopy of any changes in the gastric mucosa. And this is now being examined much more carefully. So there may be interventional techniques that can affect obesity in the future. It will be an interesting exploration to see if non-surgical interventional vascular techniques can affect weight control. So what I've tried to indicate is that this is a very dynamic subspecialty. There are many, many different things that people are considering, and we need to advance our thinking beyond just the vascular tree, certainly just beyond coronary arteries, to understand that the field is going to be moving very quickly in other directions, that for over more than 3 decades, interventional cardiology has evolved in stages. We've tried to challenge conventional wisdom and overcome many biologic obstacles, that innovation combined with a commitment to rigorous scientific principles and dedicated global collaborations, I think, has resulted in this very vibrant medical subspecialty. But these are challenging times. Interventional cardiology is at a crossroads. We're under financial constraints. We see the reemergence of medical therapy, bypass surgery in many clinical trials suggesting that in complex disease that bypass surgery may be preferable. And of course, as we said, the financial pressures threaten to limit future vascular interventional growth. So I think now we have to rediscover past success by extending the interventional model to other unmet cardiovascular needs, like structural heart disease. I think the breakthrough emergence of transcatheter valve therapy is the first step as interventional cardiology enters this new phase of diversity and creativity, that the interventional community must respond by embracing change and providing the milieu for future growth. So I would conclude by saying that there's never been a better time to be an interventional cardiologist as we look towards the future, but it's going to be necessary for everybody to adapt and evolve as we extend this model from standard vascular intervention to many other disease states and many other creative, remote catheter-based treatments of common diseases. So I believe that interventional cardiology is alive and well. And in the past 35 years, I think we've demonstrated that the remarkable effects in patients with cardiovascular disease have distinguished this subspecialty as being perhaps among the most important subspecialties in all of medicine. So I want to thank you for your attention, and I'm hopeful that even though I couldn't join you this year, that next year that I'll be able to join you, and that many of you will be able to come to TCT this year and share some of your observations and your expertise with the very large global audience. So it's delightful for me to have an opportunity to speak with you, and I wish you a very successful meeting. And again, I want to thank Sushil and Srinivas in particular for their patience and their kindness.